So good evening, everyone. It's my pleasure to present you some information on intratumoral injection. So just for you to know, I'm a head and neck surgeon from Institut Curie in Paris. My disclosures. So let's start with some basic points on the injection. So it's a one-time injection, as we said already, so just once prior to the first fraction of radiotherapy. It's intratumoral in general, but just for prostate, it could be the whole organ that needs to be injected. The dose, so the product itself is always the same, but what is personalized is the volume that is injection. So per organ is defined a percentage of baseline tumor volume that will be injected. And so this is calculated patient per patient by imaging. RT replanning is not required, and the product stays in place during the whole treatment and even after. We'll come back to that. And so radiotherapy can be started basically anytime, and we've been doing from day 1 to day 15 across the different studies. So just to give you some examples, it's not a full set of indications, but just some clinical situations where we are encouraged to use this radio enhancers. So first case would be fully resectable oropharyngeal tumors. So this is a T2N1, HP positive. This patient is 77 years old. He's got some medical history, so he would be eligible for surgery, but radiotherapy is definitely an option. It would be the first option for many countries, let's say. And so in this case, it's nice to enhance the radiotherapy. Another setting would be those large oropharyngeal tumors that are borderline resectable. So already, regardless medical history, you might think that such surgery for such tumor, quite large, would have a lot of functional consequences. So you might prefer to avoid it. And when you see the medical history of this 83-year-old patient, then you might think he might not. This surgery is not a good option. So again, radiotherapy is a good point. And last option is obviously the patient that don't have the choice and that that have really large unresectable tumors. And so radiotherapy is the only option. And if patients are frail or old or for any reason cannot have cisplatin, for example, it's really a good indication to have something to enhance the effect of radiotherapy. And so this is what it looks like after the injection. So what you see here in yellow would be the tumor, and the pink would be the R3. So yeah, it goes around. So this is the 3D reconstruction. So you can see that the particles are not completely even everywhere, but they're covering the different spaces, different parts of the tumor, and there's no particles outside the tumor, so it's not leaking in the healthy tissues. So here is an overlook of the different patients that were injected so far. So let me see if this works. Yeah. So different indications, as said before, so soft tissue sarcoma, head and neck, liver, prostate, rectum, and lung. Here's the number of patients, and one thing that is notable is that soft tissue sarcoma can be really large, and so volumes up to 450 ml have been injected. This is quite different from the other organs, so a lot of ongoing evaluation, but obviously head and neck cancers and other tumors would be smaller, and the volumes injected, of course, as smaller. And so this is quite important for to understand and have the readout on the severe adverse events. So again, in the soft tissue sarcoma cohort, you can see that there was grade 3 severe adverse events, all kind of related to the volume injected locally, so kind of pain and one complication. Head and neck, there was no severe adverse events. Prostate, neither, and then liver, just one bile duct stenosis. For the largest cohort, that would be the phase 3 for soft tissue sarcoma, so among the injected patients. Here, so 10 severe adverse event grade 3-4. So some of them related to the injection, the volume, and some kind of systemic reaction that would have many vasovagal symptoms, such as hypotension and maybe some immunological response that is under evaluation. And so here is how it presents in the different organs. So here are the particles injected in the soft tissue sarcoma, liver, and another oropharyngeal tumor. And this is so 24 hours after radiation, and this is what it looks like after radiotherapy, so it's several weeks after. So you see that the particles, they really stay in place and they don't go in the healthy tissues. In the same line, if you look at the body kinetics data, so again, this is from the soft tissue sarcoma cohort. So what you see, so sorry, it's really small here, but this is just the end of the injection. And this is the maximum percentage of hafnium that was found in the blood, so a lot of 0%. And it goes down really rapidly, and after 1 hour, there's no hafnium detected in the blood anymore. So something really local. Right. So in summary, I think we can say that we have been injecting 227 patients in the different organs, and that is 58 head and neck patients, and it was really like feasible and safe. All the patients really received the radiotherapy, and the particles, they remained in the tumor in all cases. So the recommended phase 2 dose is 22% for the head and neck tumors, and because of their larger baseline volume, it's only 10% in the soft tissue sarcoma. In the other cohorts, the evaluation is ongoing with different doses up to 42% for liver. And so, in general, R3 is really an option to get an enhancement of the radiotherapy for our patients, and especially in the frail population that cannot have either surgery or heavy chemo. Thank you.